Hi, my name is Luciano Costa. I'm a myeloma physician at the University of Alabama at Birmingham. At the ASH Hematology meeting, I'm also presenting in behalf of my colleagues from University of Alabama at Birmingham, Vanderbilt, MCW, Medical College of Wisconsin, and Oregon Health Science University, the results of the MASTER study. This is an investigator-sponsored trial that was performed by the COMET, which is a consortium to overcome multiple myeloma through innovative trials. This is a combination of Daratumumab, Carfilzomib, Lenalidomide, and Dexamethasone for induction therapy, followed by Autologous transplant, followed by consolidation, also with quadruple therapy. The most innovative aspect of this study is not only that it uses quadruple therapy, but perhaps for the first time in myeloma, uses MRD not only as an endpoint, but as a decision factor. So patients have MRD measured by next generation sequencing at each step of the therapy. So after induction, after transplant, and after each block of 4 cycles of therapy of consolidation, if that is utilized. Once patients have two consecutive MRD negatives, for example, after induction and after transplant, less than 10 to minus 5, then the patients stop therapy and they enter a treatment-free observation and MRD surveillance, where they're not on any treatment, not on maintenance, and they're monitored clinically and by MRD for the resurgence of of disease. We're presenting at the meeting results of 81 patients who have started the therapy and have had at least 2 cycles, and 42 patients who have actually completed the transplant part already. The results are very encouraging. All patients responded at the end of 2 cycles, including 2/3 of those patients already in VGPR. At the end of induction, close to 90% of the patients are already in VGPR or better. And with transplant and with deployment of MRD-based response-adapted post-transplant consolidation, 95% of the patients are reaching stringent complete remission. Most exciting is the MRD data. After induction, already 40% of the patients are MRD negative to 10 to minus 5. That increases to 73% after transplant, and that reaches 82% with deployment of MRD-based post-transplant consolidation. When you look at the level of 10 to minus 6, 63% of the patients are reaching MRD negativity to 10 to minus 6. This is very encouraging, not only because this shows one of the highest, if not the highest, rate of MRD negative remission ever reached in the upfront setting, but also provides the patient a path that is free of the toxicity and the cost of maintenance. This trial also enrolled patients with a slightly different demographic that we're used to see in upfront trials. 20% of the patients were 70 or older. Close to 1/3 of the patients were high-risk cytogenetics, and more than 20% of the patients were for racial minorities, mostly Black patients. And that really is an important thing, as those groups have been underrepresented in most upfront trials. Of course, it's a single-arm trial, and we look forward to the future to observe particularly how the patients who have this deep confirmed remission fare without any further therapy.